So, let's do some orthopedic tests. We need a model and we need a doctor. Who wants to be the model, who wants to be the doctor? Let everybody jump at once. Model, we need a foot model, somewhere like right in this area. Right in this
Very good,
area.
they don't wanna see.
Either one of you two want to be the foot model? Have you had a pedicure lately?
For sure.
I don't care. I'm
We don't-
married.
You know what?
It doesn't matter.
Good answer.
I don't
Oh,
You forced me into that, by the way.
I did?
Yeah, I'm still upset with you.
I forced you into the marriage, or what did I, what did I force you into? I missed that. Wow. I'm sorry if I did something. Okay, so now we need, okay, then you're the doctor.
Me?
Yes.
I'll be the doctor.
You're the doctor. And so we're gonna say your patient has some instability in the ankle. Instability in the ankle. Now, for that to happen, they've had some type of a sprain, and so what ligaments are we gonna be testing? Anywhere in there for instability?
Deltoid ligaments,
Deltoid ligament, the
palpation,
anterior talus, good. So let me see you do a couple of tests for either anterior, posterior talofibular, or the deltoid ligament.
I don't remember that. Give me the name. Scoop forward.
Scoop,
Scoop.
scoop forward.
So, I don't remember the name, but you can distract here.
Okay, so you're pulling the
Yes.
talus forward, right?
And we can pull it backwards.
And you can push it
test
backwards, yes.
Anterior
And
and then posterior.
So what test do you think that is? It's just like the one we have in the knee.
George.
Drawer test. Anterior drawer and posterior drawer. And do you know what ligament is tested with the anterior drawer?
The anterior
Yeah,
talofibular.
very good. And the posterior drawer?
Posterior talofibular.
Very good, very good. Okay.
Yeah.
Okay, grab another doctor. Thank you, you did a very good job, Anna. We need another doctor. Anna, you can pick whoever you want to be the doctor.
Don't let me do that. That's mean. You pick.
Luis,
Oh, let's go.
come here, dear.
Okay, we still have some more instability in there, Luis. Can you do a test or two for more instability?
Oh, yeah. So medial or lateral?
Okay, and when he's doing the medial and lateral stability test, and that's what it's called, it's kind of an easy one to remember the names, you want to be back on the hind foot. Okay, so you don't want to be pushing over out like at the metatarsals. You want to get right down there on the calcaneus, and you're going to push it medial or lateral. Has everybody got that? And that's the test you're going to be doing for medial and lateral stability. Very good, thank you. Send someone else up, Luis. We're gonna do one for. We're gonna do one for Achilles tendon integrity.
Achilles tendon.
I'm gonna refer you out.
Achilles tendon integrity. Do you remember a test for that?
Like in my
Can you do
The
it?
calf.
She needs to go.
Do you have a DVT? Let me see.
Right ankle prone?
Okay, she doesn't have to go prone. Now,
I
that's
don't?
generally the way you do it, and probably the best way to do it.
Okay.
But how else could you do it? How could you do it here? Can anybody help us?
Probably has the leg
No, the
elevated,
table.
'cause you wanna squeeze the calf.
Yeah, not so much the leg elevated, but what? Uh-oh.
Oh,
He's
come on.
coming in to give you some
Hey.
Can you do the other side so we can video it, please? Please? No? Okay.
Look at that knee.
See what he's doing? What's he doing?
Squeeze the calf.
He's not supporting the leg. What's he doing that's enabling him to do that?
He's,
Putting it into
supporting
He's
the,
pushing the foot into dorsiflexion with his hand. Now, you can do that prone, which is a very good way to do it. The reason why you don't do it just seated is because the foot naturally goes into what? When it's relaxed.
Plantar flexion.
It goes into that plantar flexion. So you have to take the ankle and push it into dorsiflexion in order to do that test. Very good. Good job on that. Okay. Does anybody remember how to do Berger's test? Berger's test.
Oh,
And anybody
yeah.
remember what it was for?
vascular.
The legs.
It's
deficiency?
Blood problem.
Yeah, it's definitely a clotting problem, right? They call it Berger's disease, right? And so, it causes clotting in the smaller veins and arteries, okay? So, how would we do that test? Does anybody remember? Uh-oh, right here.
Hey.
Austin's got it.
We're gonna have you lay back, please.
Yeah, they do. Look
So
at
go ahead, extend this leg. So you would bring this leg up and you would see it getting discolored. So
Yes, you're gonna
How's
see
it test?
if it starts to blanch and turn white, and you can hold it there for up to 3 minutes, right? That's a long test. So then what do you do? No, stay there, Costa. What do you do? So now we do that, we see, wow, there's no blood in there. Should there be blood in there?
yeah.
Yes, there should be blood in there. But if there's not, then they're definitely having this trouble. They call that thromboangiitis obliterans. Does anybody remember that name? Thromboangiitis obliterans. So next what we're gonna do, we need to see if it refills, right? So it's all drained out. Now, we're gonna see how long it takes to refill. So you're gonna lower it below the table, and at the same time have your patient sit up. And you're gonna, don't let go of the foot, you're gonna continue to watch it to see if you get that coloration back in the foot. And it might take quite a while for it to happen, okay? So you wanna time that and see what's going on.
You want it fully extended or just relaxed?
I'm not sure if it matters too much. I know you wanna keep it off the floor.
Okay.
And so probably extend a little bit. It might be a little easier on you as the doctor to control the situation and to see. But I don't think it inhibits it one way or another if the knee is straight or not.
So the leg elevated up to 3 minutes, him doing that, when you bring it back down, is there a time frame for that?
It should refill rather quickly, but it may take a couple minutes. for it to do.
1 to 2 minutes.
Okay?
You need to know that just in case.
Does everybody remember that? Way to go, post the way to step up there and do that. Okay, we have two tests for a high ankle sprain. Does anybody wanna do one?
I'll do one.
Come on over here, Reg, which one are you gonna do?
Cross leg, so, could you cross one leg with the
I sure can.
other? And then,
No, Reg, that's wrong. You're, put her in the right position.
Put me in the right position, Reggie.
Okay, so it needs to be more like this, and then she's gonna
There
have
you
to
go.
apply pressure here.
That's right. And from my understanding, either the doctor applies the downward pressure or who? The patient can do it, right? And then they should have what? Pain and stability coming off of that, that syndesmotic joint is what that is. And it's not supposed to move that joint, but it does. And sometimes it even goes out of place when people have an inversion sprain or, and we'll talk about that. There's times you actually want to adjust the distal fibula as well. Okay? There's another one for that. And who wants to do this one? It's Kleiger's test. Anybody remember it? I thought Crystal was coming over to do it. Anybody remember Kleiger's test? Nobody know? What we're gonna do is, we're gonna have the patient slide back on the table.
Like all
A
the way
little
back?
more, yeah, just let your ankle hang over.
Okay.
And so what we're gonna do now is we want to see if we can separate the tibia and the fibula, and the way to do that is just stabilize. Don't let it don't let the leg turn, and you're just gonna go like this, and you're gonna externally rotate the foot. And what'll happen is that external rotation, the mechanism taking place between the talus here, et cetera, that's going to separate those two. That's gonna push them this way, and that will cause them discomfort. You'll have, again, some instability with that. Okay? And the last one, I don't have my nice little hammer, is our Tinnel's tap. And that is, again, we talk about it over that flexor retinaculum, right where the tibial nerve slides underneath there. And that's called what? Tinnel's tap for what? For tarsal tunnel syndrome. So we're gonna come here. This retinaculum comes this way. It comes this way. Here's where the tibial nerve comes down through, and you're just gonna tap over that. and see if that sends the reflex up through the bottom of the patient's.
And it's not supposed to, right? Or it is supposed to?
It's not supposed
Right.
to. If it's, same with carpal tunnel. You may get some, if you tap over any nerve, you may elicit that nerve. But if somebody actually has a carpal tunnel or a tarsal tunnel or a cubital tunnel, like if I hit myself here, oh, it's just not very good, right? But if they say that if you have it, and I've never had it, I don't know, have any of you ever had it? They say that when you hit that one, it really hurts. It really hurts. So I just think it's sort of like cruel and unusual punishment. I wouldn't do that to anybody, right? All right, so any questions on that? Okay. What we're gonna do is, we're gonna start, we're not gonna palpate the key ankle ligaments or anything. We're gonna do that when we get into the physical exam part, okay? But you can go over them if you want and start finding them. But what I'd like to start with today is actually the examination for, and then how to start adjusting these bones. Now, what I want to do basically for the rest of the class is show you how to motion palpate these. And there's a very specific way to do it that I want you to do it. In fact, if you don't follow this scheme when you're doing it, I'll mark you wrong. And the reason I'm going to do that is because there's a lot here. And if you learn how to do this, somebody taught me this a long time ago. This is a great way to screen the ankle, okay, for things that are in there. So I'd like to get this into your head. Now, on the test, if you have, you're only going to have one bone to adjust, but you'll still examine it the way we're going to show you here. Okay, does everybody got that? But we want to get this in your head. So everybody's going to have to take their shoes and socks off today when we go through this. But here's the way we're going to examine this. Now, sometimes you have a palpation table that's nice and high and you don't have to get onto your knee. Here we're just working on lower tables. So this is the way we're going to do this. Can you do the model for this as well? So what we're going to do is we're going to come here. In fact, you can come all the way out to the edge of the table. Make yourself comfortable. Or do you want to, let me turn this around. That looks uncomfortable.
It's a little awkward.
Thank you, Elise. Here you go. Have a seat right here at the edge of the table. And so, what we're going to do is we're going to take our patient, and I'm going to kneel on, when I am examining her right ankle, I'm kneeling on my right knee, okay? Does anybody, can you tell just by looking at me why it's important that she would be, why I would be kneeling on my right knee and resting her on my left knee? Can anybody tell me?
So you're out here, right? And not
Well,
on here.
yes, you want to be on the outside, that's true. That's one reason for sure.
Protection.
Because her foot's right in front of me. Does everybody see that? If I did this, then her foot's over here. And you want to get that right in front of you so that you can get this good examination. So I'm going to be looking for you to do this. And I know half the time when students do this, they want to sit down, they want to reach over, they don't want to get in position. But this is the way I want you. Okay, has everybody got that? And so we're going to start looking at the talocrural joint. And what we're going to do is you can put your thumb on the dome of the talus, or you can grab onto the sides of it, it doesn't matter. And we're just going to push her foot in full dorsiflexion and full plantar flexion. And what you'll feel as that takes place is that talus is going to slide underneath the joint, and then it's going to come forward. Has everybody got that?
Mhm.
So that's what we're feeling for, is that joint functioning right. And of course, you're going to examine the one relative to the other one, right? You can also do with a little bit of inversion and a little bit of eversion to see if it's sliding, because sometimes it slides out a little bit medial, sometimes it slides out a little bit lateral, and that will make a little difference in your line of drive when you're adjusting the patient as well. Okay, has everybody got that? The next thing we're going to do, again, it's full plantar and dorsiflexion. The next thing we're going to do is I'm going to stabilize right over top of this. And I'm going to sort of grab a hold of it like this. Does everybody see how I did this? And I'm stabilizing on the talus. And I'm going to come up here, and if you measure, you're going to come right down off of the medial malleolus and come a little bit forward, and we're going to come onto this bone right here. It's called the navicular and the navicular tubercle. Some people have a lot more prominent one, some people have a less prominent one. Then what I'm going to do is put my thumb on top of the navicular and my finger underneath it, and I'm just basically going to lift it up and down. and I'm trying to isolate that bone. I'm not trying to do this. I'm trying to literally isolate the bone and move it up and down. It sits in a little bit of, not just a straight I to S movement, but a little bit P to A in that movement. So you're gonna grab a hold and you're gonna move it back and forth just like this. The next thing you're gonna do is we're gonna palpate that first cuneiform. So I'm gonna stabilize the navicular like this, and then I'm gonna have my fingers real close, and I'm gonna come just like this. So everybody see what I'm doing? This won't work. These are little bones, they're close together, and your fingers have to approximate one another. The next thing we're going to do after we did the first cuneiform, we want to do the second and third cuneiform. The second cuneiform, we're going to come right down the second metatarsal. I'm going to be making my landmark here, the navicular tubercle, and I'm going to come down here, and I'm going to stop just distal to the navicular, and that's going to put me on the second cuneiform. Then I'm going to come down the third one, and I'm going to move it up and down. That's our third cuneiform. So everybody got that? Okay. Then just lateral to that is what bone? The cuboid. In fact, before we get to the cuboid, the cuboid, on the lateral edge of your foot, you're going to feel that there is a bump. When you come down the lateral edge, you feel that big bump, and then you go into this indentation. Well, that big bump, hand me his leg. Thank you. Don't let that fall over. See this big bump? This is the proximal fifth metatarsal head. And then all of a sudden you move into this indentation. And this indentation right here is where your cuboid is. Okay? So we want to motion this proximal fifth metatarsal head first. So I got to stabilize this cuboid. So I'm going to put my thumb right here over the cuboid like this, and then I'm just going to grab a hold of this, and I'm going to move this up and down. Okay? After I've done the proximal fifth metatarsal head, I'm going to have the patient rotate away from me just a little bit this direction. I'm going to come up like this, and I'm going to stabilize on the calcaneus. Does everybody see how I have a hold of that? And I'm going to put my thumb underneath the cuboid and my finger on top of it, and I'm just going to push this up and down like this. Then I'm going to come back again, and I'm going to stabilize the talus, and I'm going to put my hands together just like this. Will help you do this. I'm going to stabilize the talus, and I'm going to go and motion my calcaneus. That's a subtalar joint, and I'm going to motion that. They say most of inversion and eversion takes place there anyway. But we're going to motion this just like this. Okay? Then the last thing we're going to do is the distal metatarsal heads, where a lot of people have trouble here. So we're going to be lifting the distal metatarsals right through here. We're not lifting the phalange, we're lifting the distal metatarsal. Because when people have trouble with this, if maybe it's from a plantar flexion injury, or from wearing high-heeled shoes, it pushes these back. Does everybody see that? And when it does, the distal metatarsals move forward. So what I'm going to do is I'm going to come up underneath the distal metatarsal. I'm not down here on the phalange. She'll be able to tell you I'm back here, all the way back here, and I'm putting my pip joint right up underneath there. I'm grabbing hold of the toe, and I'm lifting it up. I'm going to go to the second one. I'm going to lift it up.
Just a small
Lift it up. Then I'm going to go to the third.
She wears heels.
And I'm going to go to the fifth one, all the way across. But do you see how hers were? They should be taken care of regularly until they get strong and start to maintain adjustment. But she may not have any trouble with them, but she will in the future if she doesn't maintain the motion in those joints. Okay? You'd be surprised how that simple adjustment there changes people's lives. It's simple. And all of a sudden, it's just like, wow, they think they have a new foot. Okay, does anybody understand? We're going to go around. I know we talked a lot. We're going to talk about it very slowly as you're going through. We'll help you do each one of these bones. Thank you very much for being our model.